Today we'll be discussing the anatomy and a few important conditions that affect the orbit. The anatomy lecture comes from Anatomy Zone and will be played now.
Hi, this is Peter from Anatomy Zone, and in this tutorial we will be taking a look at the anatomy of the bony orbit. This video is a collaboration between Anatomy Zone and teachmeanatomy.info. Check out the links in the video description below for some useful articles to accompany this video tutorial. The bony orbits, or eye sockets, are bilateral and symmetrical cavities in the head. They enclose the eyeball and its associated structures. The orbit can be thought of as a pyramidal structure, with the apex pointing posteromedially into the optic foramen, and the base situated anteriorly, opening up into the face and formed by the orbital rim. The boundaries of the orbit are formed by 7 bones. From this anterior view, you can see the frontal bone in red, the maxilla in purple, the zygomatic bone in light blue, the sphenoid bone posteriorly in yellow, and the ethmoid bone in orange. Looking here at the medial aspect of the orbit, you can see a better view of the lacrimal bone in green, the ethmoid bone in orange, and a small part of the palatine bone in dark blue. Let's take a look at the base of this pyramid and the boundaries of the orbital rim. Starting superiorly, you can see this border formed by the frontal bone. The medial border is formed by the frontal process of the maxilla. The inferior border is formed by the zygomatic process of the maxilla and the zygomatic bone. The lateral border is formed by the frontal process of the zygomatic bone and the zygomatic process of the frontal bone. Now let's take a look at the other components of the bony orbit. The roof, or the superior wall, is formed by the frontal bone and the lesser wing of the sphenoid. The frontal bone separates the orbit from the anterior cranial fossa. I've just switched to a view to demonstrate the sphenoid bone, which can be a confusing bone to understand. From this anterior view, you can see the lesser wing, the greater wing, and the superior orbital fissure. And to illustrate this from within the cranium, I have rotated around to show these structures from a posterior and internal view. The floor, or inferior wall, is formed by the maxilla, the palatine and zygomatic bones. The maxilla separates the orbit from the underlying maxillary sinus. The medial wall is formed by the ethmoid, the maxilla, the lacrimal and sphenoid bones. The ethmoid bone separates the orbit from the ethmoid sinus. The lateral wall is formed by the zygomatic bone and the greater wing of the sphenoid. The apex of the orbit is located at the opening to the optic canal, which is known as the optic foramen. The base, as we have seen, opens out into the face and is bounded by the eyelids. It is also known as the orbital rim. Let's take a quick look now at the contents of the bony orbit. The bony orbit contains the eyeballs and their associated structures. These include the extraocular muscles, the eyelids, and several nerves and blood vessels. The extraocular muscles are responsible for the movement of the eyeball and the superior eyelid. We'll take a look at the extraocular muscles in the next tutorial. In terms of the nerves within the bony orbit, there are several cranial nerves which supply the eye and its structures. These include the optic, the oculomotor, the trochlear, the trigeminal, and the abducens nerve. There are also several blood vessels within the bony orbit. The eye receives blood primarily from the ophthalmic artery. Venous drainage is via the superior and inferior ophthalmic veins. Let's take a look now at the pathways into the orbit. There are three main pathways by which structures can enter and exit the orbit. These include the optic canal, the superior orbital fissure, and the inferior orbital fissure. The optic canal transmits the optic nerve and the ophthalmic artery. It opens into the middle cranial fossa. The superior orbital fissure lies laterally to the optic canal and transmits several nerves, including the lacrimal, the frontal, the fourth cranial nerve, which is the trochlea, the superior and inferior branches of the oculomotor nerve, which is cranial nerve 3, the nasociliary branches of the ophthalmic nerve, which is the first branch of the trigeminal nerve, cranial nerve 5, and it also transmits the abducens nerve, cranial nerve number 6. In addition, it also carries the superior ophthalmic vein. The inferior orbital fissure separates the lateral wall of the orbit from the floor of the orbit. This fissure transmits the zygomatic branch of the maxillary nerve, which is the second branch of the trigeminal nerve, cranial nerve 5, as well as the maxillary nerve itself. In addition, it transmits the inferior ophthalmic vein and also some sympathetic nerves. There are also some other minor openings into the orbital cavity. The nasolacrimal canal, which drains tears from the eye to the nasal cavity, is located on the medial wall of the orbit. Other small openings include the supraorbital foramen and the infraorbital foramen, which transmit small neurovascular structures. The infraorbital groove begins posteriorly at the inferior orbital fissure and passes across the floor of the orbit to connect with the infraorbital canal, which then opens up onto the face via the infraorbital foramen. So that's the anatomy of the bony orbit. For more anatomy articles, check out teachmeanatomy.info, and for more anatomy videos and flashcards, check out anatomyzone.com. If you have found this video useful, click on the like button below and subscribe to Anatomy Zone for more video tutorials. Thank you for watching. The 3D models used in this tutorial were powered by the excellent and free Anatomy Learning app. Check it out for yourself.
But just to refresh and to give some context how to remember the bones of the orbit, just remember that the roof is comprised of the sphenoid and the frontal bone, the lateral wall, the sphenoid and the zygoma, the floor, the palatine, maxilla and zygoma, and the medial wall, the sphenoid, maxillary, ethmoid and lacrimal bones. And this useful mnemonic over here can be used because the sphenoid, as you can see, is present in all of the roof, lateral wall and the medial wall, but not in the floor. So and also there are 2 bones in the roof, 2 bones in the lateral wall, 3 in the floor and 4 in the medial wall. So the mnemonic is 2, 2, 3, 4, sphenoid everywhere but the floor. And then you can also notice that each of the consecutive walls share a bone with the previous. So the roof and the lateral walls of the orbit share the sphenoid, the lateral and the floor, the zygoma, the floor and the medial walls, the maxillary bone, and the medial and the roof, the sphenoid bone. Just to look at definitions of bulging eyes, just remember that proptosis refers to only bulging of one eye, and the best way to actually compare the 2 eyes, whether the one is proptosed or not, is to look from the top. So you look down basically over the eyebrows and the nose of the patient, and here you can clearly see that there is proptosis on the left. Then per definition, exophthalmos means that there is proptosis of both eyes. Actual proptosis means that the eye is bulging, but it is still, but it's not looking to the left, to the right, up or down. While the non-actual proptosis means that the eye is bulging, but it's looking off to the side. So this, the one eye, as you can see, with the red reflex, with the light reflex, in the middle of the pupil, and the other one is here on the side of the pupil, which means that it's off to the side. So that is non-actual proptosis. Just remember that any child with proptosis needs urgent referral to ophthalmology, because while the most common cause of proptosis or exophthalmos in an adult is thyroid eye disease, in children it is usually either neoplasm, and there can be very serious malignancies such as rhabdomyosarcoma, or even the late stage of retinoblastoma once it has spread to the orbit, or it could be a serious infection such as orbital cellulitis. So any child with proptosis needs to be referred to ophthalmology as a matter of urgency. And just to illustrate, we often see patients with only mild bulging coming from the orbit, with early rhabdomyosarcoma, although this lesion is already quite large. But they, if left untreated or undiagnosed, they can present with absolutely explosive growth that can, over a period of 2 to 3 weeks, reach this size that I'll show in the next photograph. And we have seen cases like this before in our own clinic. So just be very worried whenever you see a child with proptosis, even if the child is systemically well. It may be underlying malignancy just waiting to explode in growth. So one of the main conditions that we're going to look at today, we're not going to look at all the conditions of the orbit, because you can basically fill an entire thick textbook with all the conditions that can affect the orbit, mostly because the orbit houses so many different types of structures: fatty tissue, veins, arteries, nerves, and as a result, there are an almost limitless amount of things that can happen to the orbit. But we're going to look at a few important things, and the rest we'll deal with when you do your clerkship with us at ophthalmology. So the orbital septum can be a difficult structure to understand, and especially to understand where exactly it lies. So here the orbital septum lies right here. It starts at the rim of the orbit, and it basically goes down and meets up with the posterior lamella of the eyelid. Okay, so this over there is the orbital septum. This over there is the orbital septum. Everything in front of it is preseptal, and things behind it is postseptal or intraorbital. So just to delineate where the orbital septum sits. And when we talk about orbital cellulitis, we mean postseptal inflammation of the orbit. Okay, so you can see here that all the structures in the contents of the eye, the fat especially, is red and inflamed, and on a CT scan you can see what we call fat stranding. And what you need to know is anatomically that all of this sits behind the orbital septum, while when you have the almost sister condition of orbital cellulitis, which we call preseptal cellulitis, it only affects the structures in front of the orbital septum, and the orbit and its structures remain intact and functional as usual. So patients with orbital cellulitis are really seriously ill, toxically ill, with a high fever, while patients with preseptal cellulitis are generally happy walking around and not toxically ill. In preseptal cellulitis you do not get proptosis, while in orbital cellulitis you do. You usually get axial proptosis, which just means that the eye is being pushed forward without the cornea being pushed to the side at all. In this specific case, you have orbital cellulitis, but also with a concomitant intraorbital abscess. So in this specific case, the eye is pushed a little bit to the side. In orbital cellulitis, you also get chemosis, which is swelling and fluid buildup behind the conjunctiva, that you also do not get with preseptal cellulitis. And you get impaired eye movements. So if you ask this patient to look left, right, up or down, the eye will not move as much as the other eye. So it's called a restrictive myopathy. In this case, the restriction of the muscles result from severe swelling on the inside of the entire orbit, which basically makes it difficult for the muscles to move the eye within the orbit. The other type of myopathy is a paralytic myopathy, where there's nerve damage. That means that there's no signal going to the muscle to move the muscle, but in this case it's restrictive because of the bulk of the orbit that is swollen. So orbital cellulitis, toxically ill patient, proptosis, chemosis, and impaired eye movements, and all those signs are absent in preseptal cellulitis. So the management of orbital cellulitis, when you suspect that, is you can admit the patient straight away and inform ophthalmology about the patient. You can start on IV antibiotics. Say you want to maybe refer the patient in, or you're just treating it at your own base hospital. Start the IV antibiotics with Augmentin and Flagyl. The alternative is just a cephalosporin, but the standard of treatment is still with Augmentin and Flagyl intravenously. And all of these patients need CT scans. In fact, a CT scan is the first special investigation that we propose for all patients with proptosis or exophthalmos. And as I said, these patients need to be regarded as an urgent referral to ophthalmology. We also refer these patients on to ENT if the sinuses are affected. So in this case, this patient has a ethmoid sinusitis, but they can also have a pansinusitis where all the sinuses are involved. So either ophthalmology or ENT can drain these intraorbital abscesses, and ENT will do a washout of the sinuses. Then sometimes the abscess can spread intracranially, at which point neurosurgery has to become involved. So the other very common cause of proptosis, so either unilaterally or bilaterally, dysthyroid orbitopathy or thyroid eye disease is the most common cause of bilateral proptosis, or per definition exophthalmos in adults. But it is also the most common cause of unilateral proptosis in adults. It is an autoimmune disease, and it is caused by circulating TSH receptor antibodies binding to orbital fibroblasts. So about 90% of these patients also have concomitant hyperthyroidism, and that is why it's called dysthyroid orbitopathy. But there is still 10% of them that do not have high thyroid hormone, and these patients can either be euthyroid in 6%, or they can be in about 4%. They can be hypothyroid. In other words, there's a low thyroid hormone present. So when this TSH binds to orbital fibroblasts, they secrete glycosaminoglycans and cytokines, and these attract inflammatory cells into the orbit. Some of the orbital fibroblasts turn into adipocytes, and this makes that there is intraorbital swelling, and the most common or almost pathognomonic sign that you see on a CT scan is that the extraocular muscles are swollen. Here you have the normal extraocular muscles, the lateral rectus and the medial rectus, but in dysthyroid orbitopathy, you get that the muscle bellies swell up while the tendons actually remain thin and not swollen, while there are other conditions where the whole muscle, the belly and the tendon swells up, and by looking at a specific picture of the CT scan, you can then decide what type of condition is more likely causing this condition. So here's just another view of the muscle bellies where you can see it is clearly swollen. Then because of all the inflammatory cells that get attracted to the orbit during this thyroid orbitopathy, you get eye inflammation, again with chemosis, as we had in orbital cellulitis. And you can again get a restrictive myopathy where the eyes do not move as normal because of the swollen muscle bellies. But later on in the disease, once the disease is basically burnt out and you get some fibrosis setting in after the initial acute inflammatory attack, you can get lid retraction where the eyelids basically gets shortened, and you have this very staring appearance, and you also get lag of thalamus, where when the patient looks down, the eyes go down, but the lid does not follow. So that is what we call lag of thalamus. Just again to remind you that 90% of patients are hyperthyroid, 6% euthyroid, and 4% hypothyroid. And then we want to have all thyroid eye disease patients referred to ophthalmology. We co-manage them with rheumatology, but they often we are the ones that initially make the diagnosis on the basis of the pathognomonic CT scan picture and of when we do the thyroid functions. 90% of them have raised thyroid hormones. Right, so next we'll be looking at quite a common traumatic condition, which is orbital blowout fracture. This can happen either when the eye gets struck very hard by something like a tennis ball, or a patient gets hit on the eye. And specifically look at the bottom there, because the most common fracture that you get is an orbital floor fracture. It's almost counterintuitive because the ethmoid bone is actually the thinnest bone of the orbit, but for some reason most of these affect the orbital floor, and then you get not only the orbital fat that goes into this fracture, but often you get the muscle also being basically trapped in this fracture. And then when this specific patient wants to look up, because this muscle is trapped and held back by fragments of the fracture, this patient will not be able to look up properly. So when you look at a patient with an orbital blowout fracture, you first see ecchymosis or blue eye and swelling around the orbit, so periorbital swelling and ecchymosis. And then when you take you can just take the back of your pinky, or or you can take a wisp of cotton wool or a cotton bud, and just lightly stroke over the cheek on both sides, and then you ask the patient to compare the sensation. And with the orbital blowout fracture, because of the fact that the infraorbital nerve can be damaged, they often have infraorbital hypoesthesia. In other words, over this area below the eye and over the cheek, they don't feel skin sensation when you lightly touch on the skin. Then if you draw a line, in this case it's actually better to view from the bottom, because unlike proptosis, a sunken eye or enophthalmos is easier to see from the bottom. Over here you can see that there's enophthalmos where that right eye is retracted, compared to the left eye that is not affected. And then it's not 100% clear on this picture, but if you were to draw a line again, you'd be able to see that the left normal eye can look upwards normally, while there's restriction of upward gaze in the right eye. So this is again another example of a restrictive myopathy or ophthalmopathy, where the patient cannot look upwards. And typically what you see when you do CT scan of an orbital blowout fracture is this over here, which is called the teardrop sign of an orbital floor fracture. So again, these patients can be referred first to ophthalmology, because we would like to make sure that the patient does not have any other eye conditions like a ruptured globe or or retinal detachment, or any other trauma to the eye, especially blunt trauma sequelae like dislocated lens or high femur. But in the end, it is actually maxillofacial surgery that gets involved to fix orbital blowout fractures with plating the affected area of the fracture, and that surgery usually gets done within 1 or 2 weeks after the initial event, once the swelling has gone down, because when there is so much swelling, the outcome of surgery can be quite poor. So we have to wait until the swelling has gone down, and we achieve that with non-steroidal anti-inflammatories and with ice packs. And then, like I said, ophthalmology need to see all of these patients to check for any injuries of the different structures of the globe or the eyeball. So this is where we end this lecture. But as a general rule, whether in adults or in children, all patients with proptosis or exophthalmos needs to be discussed immediately with ophthalmology, and we can then guide you as to how the referral pathway should be affected. And like I said, there are many other conditions that affect the orbit, such as many malignant or benign tumors, different infections such as cysticercosis, etc. But we'll dive into those in more detail on the clerkship.